Hello, everyone. We're just getting everybody on board here. Welcome to the October meeting of Plan Design and Expenditures. While we're waiting for everyone to come into the meeting, I can just give a brief agenda review. Oops. Okay, so today we're going to have updates as we usually do from the other committees of the board. We have a straw proposal to consider and give feedback on. That's on the quality strategy from the Universal Health Plan. We're going to be having a discussion about behavioral health payment systems. This group already had really great, robust conversation about behavioral health benefits and payment in the Universal Health Plan. But as we're pulling together payment systems, some other issues have come up, and we wanted to bring this back. And we're lucky to have Cheryl Ramirez, who is a board member and an expert in the behavioral health system in Oregon. She'll be joining us for about an hour for that discussion. So that's great. Lee Hastings is going to give a presentation on hospital payment systems with the goal of getting us to a straw proposal by next month, if that's feasible. And then we'll have some time for reflection and comments. I will point out to the committee members that we did have a number of written comments for this committee meeting. If you're not sure where to find those, if you're on the Universal Health Plan Governance Board website and you go to our committee page, there are the meeting materials there, which has our agenda and our presentation. And then there is the written public comment that this committee has received. I would encourage all the committee members to take a look at that public comment. There's some really good feedback in there, specifically from mental health providers and the struggles that they've had with payment. So I would encourage you to read through those and consider those as we discuss it. So Isabel, are we ready for a roll call?
Yes, we are. Okay. Helen Belanca.
Here.
Chun-Wei Chi.
Here.
Thank you. Peter Addy.
Here.
Thank you. Gabrielle Andine.
That's me.
Thank you. Betsy Boyd Flynn.
I'm here.
Thank you. Mike Durbin.
Here.
Thank you. Rob Fizette. I did not see Rob yet. Tony German. I did not see Tony yet. Eve Gray.
Present.
Thank you. Rosemary Hemmings. Not see Rosemary yet. Julianne Horner. Don't see yet. Max Kaiser.
Here.
Thank you. Jim McGee.
Here.
Thank you. Peter Merritt.
Here.
Thank you. Angela Michalik. Don't see Angela yet. Jamie Osborne.
Here.
Thank you. And Tosh Rahman. Doesn't look like Tosh is here yet. Thank you. That's everybody.
Great. So before we get started, I have some very exciting news. As you all know, I have been the interim chair of this committee after Debbie Diaz stepped down from the board. We are welcoming a new board member, and so we're having a little bit of shifts in our committee participation, and I am thrilled to welcome Judy Richardson as not only a new member of this committee, but she will be taking over as chair. Judy's a family physician, and she has a wealth of expertise in health policy and economics of healthcare. And so she's a perfect fit to take over as chair of the board. I'm going to ask Judy to come off camera and just say hi.
Thanks, Helen. Hi, everybody. Many of us know each other from me wearing other hats, but I'm delighted to be working with you on plan design and expenditure. It's one of the topics that's very near and dear to my heart. So, yay. Thank you.
Yeah, so we will be, Judy's obviously here for the meeting, and we've been tag teaming it here for the past month. And then beginning in October, she will take over as chair, which again, we're really grateful for your service, Judy. Thank you. Okay, I will turn it over to Mimi to do some feedback and review from our previous meeting.
Yes, and I just wanted to add on, and apologies because it didn't make it to the slide agenda, but just after I get finished talking about the board and committee updates, Ken Leskowski from Milliman is going to have a presentation. That was on the regular agenda, just didn't make it to the slide. So he'll be right after me. So kicking off with what the board has been up to. The last board meeting was on September 18th. And at that time, actually had a great presentation from Milliman, kind of providing an overview of the scope of their work and how that's going to roll out. Had a great presentation, which you all have had the benefit of hearing already on the hospital payment models from Lee Hastings, which the board found very, very beneficial. Some things that are coming up at the next board meeting, that's why they have a little asterisk next to them. Board meeting is on October 16th. And at that time, there should be a revenue strategy straw proposal in front of the board. I'm putting the cart before the horse a little bit because that finance and revenue meeting is on October 7th, so it hasn't happened yet, but I have high hopes. So if people are wanting to tune in, either hop in on the 7th or the 16th. We did have a great operations, and I'm sort of stealing operations thunder, sorry, but there was a model that was proposed and has been forwarded to the board, a straw proposal on administrative structure, specifically around regional entity models. So that too will go before the board. And then today, our work, part of our work is to talk about a quality strategy. So as long as we get everything together and maybe make some adaptations or changes, we'll have a quality proposal. So the board is going to be very busy in the next at the next meeting in the upcoming month. So anything else from my board members who were there? Anything I missed?
No, that's great.
Okie doke. So just briefly on our other committees, community engagement and communications. Again, they've done a tremendous job. There's a completed strategic messaging guide, which is very helpful for board members, committee members to have a really good understanding and being able to communicate the work of the board. Not quite ready for prime time are the one pager and FAQ sheets. They've been developed, but they're just getting some fine tuning by the DCBS communications team for sort of for the formatting, and those will be available. And what's exciting is that the community engagement meeting preparations are starting. We had a great meeting with CECC at our last committee meeting, kind of developing the questions that we think are going to be very pertinent to go in front of those different community engagement groups. So operations, I already talked about that, just really had worked hard and have the beginnings of a great administrative structure, regional entity model. Of course, that's just part of the whole, but it's really a great start. And then lastly, finance and revenue. The also important revenue strategy should be available. And then also at our next meeting to our consultants with Echo Northwest, we're going to talk about the impact of plans on individuals and also households. So tons of work. Things are kind of picking up speed, as you may have realized. So having said that, if there are no questions, I am going to turn it over to Ken.
Sure, thank you. Do you want me to share my screen, or do you have my side? I can do it either way. All right, let me give this a shot here.
Yeah, why don't you drive?
All right. If you all can let me know when you can see this. Oh, I should hit the share button. That might help.
It's coming.
Right.
There we go. Nailed it.
Just missing that little blue button. So thanks. I wanted to take 10 minutes of your time today, just to talk about the current benefits available in Oregon and current plan designs by market. As we transition to the universal health plan in 2030, what does that mean for the average Oregonian? And I hope Oregonian is correct. If it's not, I apologize. But so I just have a couple slides here. The first one I want to show is the plan designs by market. So taking all the markets, every market, there's a wide variety of plans to choose from. And it kind of boiled those down into the average plan, the average deductible, the average maximum out of pocket, and the average actuarial value. And I've put the sample plans off to that column off to the right, just to kind of show what comprises that average. The reality of any market is that, again, going back to, there's a variety of plans. So something like the large employer market, I just don't want there to be the idea that everyone has a $2,000 deductible. Really, there's people with any large employer has maybe 2 or 3 options, maybe more for plans. So they might have a $500 deductible option with a $3,000 MOOP, and they might have up to a high deductible health plan, a $5,000 deductible, and that type of plan can have an HSA associated with it. So really, even though there's a variety of coverage, as we're looking to evaluate the expenditures of the universal health plan, this is the average deductible column, the average max out of pocket, average actual value is really an average in the market. And just to make sure everyone knows what I mean by actual value. So actual value is the percentage of total costs covered by a plan. So, top row, if there's $100 claim, that means that 95% will be covered by the plan, and 5% will be covered by the member. Obviously, that's maybe not one particular claim, but on average, that's what we mean by actuarial value. So what I'm trying to set the stage for here is, this is where we are with these average plan designs, and I've ignored copays for now, but here's where we are in Oregon now. And there's kind of 3 phases, 3 aspects of cost increases as a result of the universal health plan. So one phase is just what benefits are added, which I'll get to later. Another phase is how does the Oregon plan design increase utilization? What is the impact on costs? So, but right here, that benefit cost increase due to AV, I want to focus just on that right now. So what that means is, just from going from current plans up to a $0 plan, what can we expect for total expenditure increases before we think about utilization and benefits? So it is pretty wide varying. And these are rough estimates, very rough estimates, high level. They're not pinpoint accuracy, but something for example, the individual market, which is notorious for having less rich options. That particular population, we can expect around a 33% expenditure increase just due to going to the $0 plan. So that's really what I'm trying to communicate here. I'll switch to this slide next. And so I think it can be confusing at times, what benefits are offered, what is my coverage? So when we think of essential health benefits, the major medical plans generally cover these major service items, like inpatient, outpatient, physician, prescription drugs, and other. Not additional services, those tend to be more optional. We'll get to that in the next slide. But really, above that line, that's really what comprises somewhere around 95% of major medical costs. And plans have pretty much every health plan has coverage for all of these items. I think when it gets confusing about what is covered and what is not is when a concept like prior authorization comes in. Prior authorization being, is there is it part of your policy that you need a doctor's approval, or that the plan specifically needs to sign off that something's medically necessary or before they cover it. So I think there is a level of coverage for all of these. I think prior authorization is when it gets a little bit confusing. So that's the first thing I'm trying to show with this slide. The second thing I'm trying to show with this slide is we highlight the emergence ERR and prescription drugs. That try to say that cost sharing is essentially it's a behavior modification and a behavior influence strategy that the insurance companies use. So on benefits like emergency care and drugs, that cost sharing is integral to steerage, and it's integral to lowering costs. Typically with something like ER, you might see a $250 copay, and subject to deductible, and that's there because ER care can be, very inefficient and very costly. So we're trying to drive a member towards, urgent care, or if they can wait and go see PCP or some other alternative. And same thing with the drugs. The reason why you see so many drug commercials is because they tend to work. So drug formularies, they can be very intentionally designed, and drug cost sharing can be very intentionally designed to steer consumers towards more low-cost drugs. So I think that's what I'm trying to show here in this slide is I'm trying to highlight some problem areas if we move to zero cost sharing, and some areas where I think utilization and costs could really increase quite a bit. So my last slide, wanted just to give a rundown of the benefit differences by market. So the column on the left, the PEB plan is the set of benefits that UHP is going to be based off of. And this is a little bit of a difficult chart actually to make, just because there's a lot of gray area. A lot of these probably deserve asterisks. For example, Medicare Advantage, I've listed over-the-counter drugs as optional. So it's not necessarily an extra benefit. It can be part of over-the-counter drugs, can be part of Part D in certain step therapies, certain Part C Medicare Advantage plans have over-the-counter drug cards and it's more than just Tylenol. It's a list of medical products on a list. Medicare Advantage plans can backfill with certain food service benefits. Medicaid frequently offers in lieu of services and then value-added services. So I think what I'm focusing on here is that left column. So we have our databases. We can develop estimates of the approximate number of approximate percentage of coverage of dental in like large group, small group markets. About 30% choose dental or vision, whatever those numbers are, and we can shift that. Into total cost when we're looking at the public and the PEB plan, but so UHP will cover dental and vision. Those are listed as optional because in general they are optional, and frequently people won't choose them in order to save money if they don't think they're going to even go to the eye doctor or something like that. So, but they're services that are typically or coverages that are typically offered in large group setting. But now dental will be available for everyone, vision. And so really where all the yeses are for in the PEB plan versus no's or optionals in other columns, that's where we're going to see a little bit of an increased cost. So that's the end of my presentation for the day. Does anyone have any questions on that for the time being?
So Ken, this is Helen. I guess just to summarize, you're trying to make the point, I think, to this committee that if we expand benefits beyond what's currently offered in PEB, and cover things that are currently, only covered by some of these other markets, that alone is going to significantly increase our expenditures. Plus, the UHP would be picking up a lot of the costs of services that are currently being paid out of pocket from deductibles and copays. And so that's going to increase our expenditures. And then if we don't have some reasonable caps on utilization, that could quickly balloon our expenditures as well. Is that accurate?
Yeah, that's accurate. And I would add to that different methods of steering people towards the most efficient options.
Right. And so we have options. This committee has discussed this several times before. It's very hard to come to decisions on these things. But basically, what we're trying to get a feel for is, we have various levers that we can use to control costs, and we're trying to get a read both from this committee and from the board as a whole of which levers feel most consistent with our mission.
Right.
So one lever is that we could limit some benefits altogether. For instance, we could just say that the Universal Health Plan doesn't cover dental and vision, but supplemental insurance would be available for people to purchase that separately. So that's one way of limiting costs. Another way is to say, everything's covered by, for everyone, we cover dental and vision, but we're going to really limit utilization. You only get one visit a year or something like that, and really limit the utilization. Or we could introduce some cost sharing. And we could say that this benefit's available, but you'd have to pay out of pocket when you access it, both to discourage utilization and to sort of compensate for that. And so of those three areas of limiting benefits, putting caps on utilization for some of these, services that can get out of control, or adding some out-of-pocket costs, we're trying to get a read for what seems most palatable. If there's an order of priority, we should do this first and try not to do this, or if the committee has any particular strong feelings of what direction.
Yeah, and when you say palatable, you mean palatable in terms of the goals that you're trying to achieve here? Yeah, okay.
Yeah, we have pretty clear, objectives on this committee and on this board to offer, as robust a plan as we can to every resident of Oregon. And we want to offer services that most people need. But we also want to have a reality check about the expenditures involved in doing that. So, so we want it to be consistent with that.
Sure. One thought I have, which we can take offline and maybe for us to discuss later, is what limits, if any, in our initial expenditure results do we want to assume? And I think we can probably take that discussion offline.
Yeah. So we already decided that the PEB utilization caps would be something we would stay consistent with, that a typical PEB plan utilization caps made sense to us for certain. And then, but other than that, we were hoping to, remain consistent. Does anyone on the committee want to chime in here about answering Ken's question here, or any of the levers you think are more of a priority to preserve or utilize than others? Again, I can't see hands.
Oh,
So
Eve has her hand up, and then Betsy does as well. Sorry.
Betsy went first. Go ahead, Betsy.
I'm waffling on whether to raise my hand, but I think one of the parts that makes this really hard is understanding that we don't have capacity for all of these things to be universally accessible right now, and to try to estimate the gap between, for example, universal access to an excellent primary care home and where we are now is a difficult variable. And so My sense is that our work is not to try to solve for every single one of those variables, but to design a plan as best we can that would be the ideal. And I'm seeing maybe nod her head. But the other variable that is potentially arising right now is that Ken mentioned the increase in utilization from the baseline in a universal health plan situation. And we might see the delta between utilization. We may be about to see utilization go dramatically down if everyone drops their health insurance because the subsidies go away. There will be a lot more uninsured people who will be avoiding doctor visits entirely. And so we may even have that variable to deal with. And I just thought I'd throw that awful thought out into the group.
I suspect that we're going to have to use a variety of the levers and options presented. You know, I think it might be interesting to see about, is there a pathway we could follow where certain types of care have no out-of-pocket expense, and that might be primary care, it might be drugs within a formulary, it might be if you follow all the steps in the process before your MRI and all the other pieces. But if you step outside of that, there would be, there might be a financial impact. We will have to be aware, though, that that would increase complexity because those people who qualify for Medicaid, I don't believe we can charge any kind of balance billing for in this system if we are going to continue to receive dollars from the federal government to support the program. And someone correct me if I'm wrong, because I'm on the edge of my knowledge here. But I think we should look at what is covered and what isn't. I agree that there are going to be limitations related to access. It doesn't mean that we can't solve those problems over time. I think what might be nice is if we could really get just the clear actuarial assessments of, you know, this change leads to this cost and this change leads to this cost. And kind of like we heard in the last meeting where we can toggle things to see what we can do to minimize the burden and the impact going the other way, but be realistic about the dollars that we have.
Yeah, and just to pipe in, I know there's more hands raised, just to pipe in, Eve. That's your point is really in line with what I'm trying to communicate here. I don't want so ER to me is one where like you could see ER utilization go up by 200% more from going to like $0 cost sharing on ER, and that's just not. I mean, that's not good anywhere. It's not like it's just too expensive. It's not people getting the right care. It's not optimizing care. But I'll stop there because I know there's other hands up.
Let me jump in for 1 second to remind the committee about a decision we already made regarding Medicaid. Eve, you brought up a good point. And Ken, I don't think we clarified this with you, but we've already decided as a committee that the Universal Health Plan already has sort of 2 tiers because OHP, folks that qualify for OHP, not only do they have 0 cost sharing, but they are entitled to certain benefits that the rest of the population is not, for instance, long-term services and supports and non-emergency transportation and ESPDT services for kids. And so there's a set of benefits that the OHP population gets that the others on the plan will not get. And in addition, they do not get any cost sharing. And so there's already like a universal health plan and then sort of like a universal health plan plus for folks who would qualify for OHP. So that's already designated. So if there was some cost sharing involved in the UHP, it would only apply to the I don't know how to refer to the population other than the folks that do not qualify for OHP. It would only apply to them. And then just recapping, like we already did agree that like some utilization caps are reasonable and we base that on PEB. I guess mostly what I'm hoping to get a feel for is cost sharing? And is this committee mostly in agreement that some cost sharing for potentially high utilization services makes sense? Or do we want to, what we talked about before is like run the numbers with no cost sharing at all for anything, and then institute some cost sharing for some high utilization services and kind of do a side-by-side comparison? That's kind of like the main question.
Right, I'm gonna call out some names. Gabriel, I don't know if you're Gabriel or Gabe. Help me out.
Either one's good. Most people say Gabe, but whatever.
Okay, that's what I was thinking. I didn't want to be, rude. Anyway, you're up.
Some people call me Shorty. No, thanks, Helen, for clarifying that. That's part of the point I was gonna make. I thought, if my memory serves me, that this group had previously voiced a fairly consistent message about not wanting to have cost sharing. Although perhaps there ought to be more discussion about whether that should be considered for people who aren't Medicaid eligible, or the sort of basic UHP. It seems to me that part of the challenge with developing any cost sharing model is how are we doing, how many tiers are we doing, and how much extra administrative burden is that to sort of execute that. In terms of the different levers that are being discussed today, the most obvious ones to me seem to be looking at which services are covered, and let those be the levers themselves. Like, this is how much money we have, how much does it cost to turn on the dental or turn off the vision or the fertility service, or whichever it is. Personally, I think the issue of looking at utilization caps is compelling, and I would love to imagine a scenario where some arrangement of utilization cap sort of nudged people toward the right type of care in the right type of setting. I would love to decompress the emergency room and get those people into primary care. But like Betsy says, like it's not like we have a lot of robust remaining bandwidth in primary care right now either. So for what that's worth.
And I'll just respond, Gabe. You're absolutely right. Both the board and this committee, our initial goal, our principle, I guess, that we were trying to stick to was no cost sharing at all. We definitely talked about that. And I guess now that Milliman's on board and we're starting to do some of the actuarial work and starting to look at the costs of it, we just want to like raise the idea again and say, is there any appetite for like at least doing a side-by-side comparison, coming up with a plan that has zero cost sharing and with some projected increase in utilization, and then proposing at least, a plan that involved some cost sharing. If this committee says no cost sharing ever, like we're just not going to go there, that's understandable. But just the idea of like, if it gets to where the expenditures are just, losing control, and we know that cost sharing is one way to, you're right, would increase administrative burden, but would also sort of help us maintain our expenditures at a reasonable level. Does this committee feel like that's worth exploring, or should we just leave that off the table?
Chunwei was next.
As we consider the costs and services, one factor we haven't seriously considered yet is the shortage of providers. So, for example, right now, quite a few of medium and small cities, such as Corvallis, are experiencing very significant shortage of physicians and nurses. And that will have a huge impact on access and costs once we implement the universal health plan. So that's a separate issue, but related to costs that we need to consider. I mentioned in one of our board meetings that one scenario we want to avoid is people having universal health care but have no access to health care. And that's primarily in small cities and rural area. So that's one thing to consider, because just because we have universal health care doesn't mean people will automatically have access to more care, particularly in area with shortage. And regarding cost sharing, I suggest maybe our policy analysts can do a summary for World Bank. World Bank in 1980 implemented so-called user charges. That's mainly for countries that used to provide free universal health care, but with a shortage of finance. So they suggested implementing user charge, but then in the early experiment, they run into equity problems. So they make some reformations. And so World Bank has a rich literature and resources in helping to guide that user charge or cost sharing may not be an either or question. It's a matter of what kind of services should not implement user charge and what kind of service may be appropriate to implement user charge. And so if we ever consider to implement cost sharing, I think the World Bank's literature will be a very, very helpful guideline.
That's great. Thank you, John Wei.
Tony.
Yeah, I really appreciate the question, Helen. I wanted to reflect on some comments earlier. My personal opinion, as far as the current structure of the healthcare system, is leading to our primary care deficit and leading to the challenge we find as far as our workforce.
Yeah.
So us solving all issues here, we're probably not going to do that. I think we should be attentive to that, but I don't think that should be prohibitive, moving forward. And I think that's our charge here. I would estimate probably that having options available for the governance board and the investigation that Ken and Milliman can do for you regarding utilization versus the changes in benefits, I think would be instructive. When it comes to the question of what's palatable is, how much are we all going to pay? And I think just sharing those. So my personal opinion is that I think that it would be preferential to ideally optimize no cost sharing, but across many different nations that have universal health care, there are some elements of cost sharing and certain tiers with that. Again, I think it would be ideal for us not to do that. I think utilization are tools. It's just how you use those tools. And right now in the current system, it's overused to the detriment of people having barriers and limitations. But I think you could do it in an equitable way. So I think an investigation, unfortunately, for Milliman would be to look at a number of different avenues here. So it's a big ask, I would say. But if your question is to not to steer to look at a couple different approaches to this, I think it'd be wise for us to have more information looking at the trade-offs, whether if you have cost sharing, whether if you have the utilization in a certain way. I think focusing on our health equity goals and really what we're restricted from Medicaid is, we've already determined that in that third of the population in Oregon that is on Medicaid, that cost sharing is not going to be a tool we can use for that population. And I do like the term of enhanced benefits there, supporting that community. I would offer that we should keep that.
Yeah.
And Jim has his hand up as well.
It seems to me we're having this discussion in a vacuum without some understanding of where cost savings will originate from a universal health plan. We don't know how much money we have available to spend for additional coverage. So I think I don't know to what extent that work has been done. I'm sure it has, but that's the side by side you really need is where are the sources, what money is available from savings and where can we spend it?
Yeah, and that you're right, Jim, of course, and that's definitely coming. And there will certainly be savings realized with this plan, and they're working that into the revenue strategy model. But all of the money that's currently in the system, from people paying out of pocket through premiums, through deductibles, through copays, all of that money will have to be made up for in the system with a tax, right? And so we can institute, or recommend a tax that would cover all of these services with no copays, but the tax would be really high, personal income tax. And so the idea is if we can manage our benefits and utilization so that we can limit how much taxes would need to be recommended, that would be ideal as well. There will be savings, but there will also be new taxes, and we want to try to limit those.
And then I don't know if you can see the chat, Helen, but I just wanted to say Angela posted, I do think how much this costs with voters will be a big issue. Agreed that it would not be bad to explore side by side a few select areas where cost sharing may be a tool we want to use.
Thank you. Yeah. We are a little over time. If anyone has any final comments, I don't know if anyone else has their hand up, and then we can move on from here.
Nope, no more hands.
Ken, do you feel like you got the information you needed from this?
Yes. And sorry, I went over again, but I do. The thing I'll end on is that I'm not here to try to force any plan that's not part of your goals. I'm just here to communicate where I think, as a pricing actuary, where I say, oh, that's going to be a challenge, and that might increase costs a little bit more than we realize.
Yeah. Well, we can we can talk offline with the staff and come up with maybe 2 or 3 different scenarios for estimating expenditures, one of which would have no cost sharing, and then maybe 2 additional ones that institute a little bit of cost sharing, and then we'll bring it back to this committee maybe to just take a look at that and get a sense of what that would be like, if that works.
Yeah, I have some ideas too that I want to run by.
Great. Yay. Thank you so much for joining us, Ken. Appreciate it.
Thanks for having me.
Okay, Mimi is going to be talking about our quality of care strategy straw proposal.
Absolutely. So thanks, everyone. I hope that people had an opportunity to take just a quick look at the quality of care strategy straw proposal that is available with the meeting documents. I do have slides, and we're going to kind of go over it at a high level. This is absolutely a proposal, and so really hoping to get feedback during this meeting for things that have been missed. I will say, everyone get comfy, because it's definitely sort of a meta ride that we're about to go on. So all right, we'll take the next slide first. All right, so what I'm hoping to do is kind of talk about what this proposal is built on, in other words, the basis for it, and then talk about what is actually in the proposal. In other words, outline the steps for policy and strategy development, and then really in the discussion, what is missing, what is superfluous, what can we get rid of, and then if we come to some kind of agreement, it doesn't have to be perfect, but then take a roll call vote to see if this is something that we feel should move forward to the board, or if it needs to go back under construction for a little bit longer, and either one is completely okay. And like I said, Jim, you just holler out whenever you get to a point where you're like, I have something I want to bring up. Same with Angela, same with anyone, really. All right, did want to start with a little bit of level setting. So because the topic is so large, having a definition of healthcare quality is very helpful. This is the IOM's definition, which is really essentially used throughout the world. This is what WHO uses too. So when we think about quality in healthcare, so it is really degree to which services for individuals and populations, I think that's important, increase the likelihood of that desired health outcome, and they're consistent with current professional knowledge. So again, that's just the definition of healthcare quality. It's not a healthcare quality system, but it's really what we're kind of starting with. All right, next slide. Okay, so what is in that preliminary proposal? Well, first, obviously, using an evidence-based framework, this certainly didn't make something out of nothing. There are a lot of quality frameworks about. One thing that is a little bit different is the recommendation that a universal health plan or a state would create a quality policy and a quality strategy sort of in tandem, because they do slightly different things, and we'll get into that a little bit. What do you want that quality proposal and strategy to do? Well, if we're basing it on promoting the goals of the quintuple aim, and I'll go over that, really from the discussions that we've had, and certainly from the literature as well, prioritizing simplicity, reliability, transparency, and efficacy. I think we kind of heard that over and over again in discussion, and what have been the challenges that people have experienced working on the front lines trying to deal with quality measures. And so it is the strategy and policy work itself can be built by using these 8 elements that are outlined in the WHO handbook for quality policy and strategy. So that's a big part of this proposal. Okay, so we're ready to roll. We'll keep going. So again, why 2 things at once? Why can't we just have a strategy? Why do we need a policy? But I think it's important because, of course, a quality strategy is going to have to be nimble, but a policy is really, you hang your hat on those agreed upon goals with an explicit statement of intention and principles. In other words, why are you doing this, and what is it that is trying to be achieved? So that really is the framework. And then the strategy is the how. It's the roadmap. How is this going to happen? And it can be very dynamic, but it has the specifics in it, the objectives, activities, and measures, etc. So I want to stop there for a second and just see, does anyone have heartburn with that? Jim, fire away.
One of the things that I found myself asking as I was reading the document was why. That question was not, I don't think, specifically addressed. And I say that in this context of, do we want to measure and to discover the current state, or do we know specific problem areas that we want to address?
So
or is it both? Is it both?
Yeah, I would say this proposal is even a step back from that, Jim. This is not what are we trying to fix? This is how can a comprehensive quality policy and strategy be created? And if your question is what, I'm not sure if your question is why is that needed? Is that your question?
No, I think
okay.
the part of the quality strategy is to ask the question: are we measuring current state, or are we trying to fix desired states?
Yes, and yes, absolutely. And I think as we go along, we'll get into that a little bit. And again, definitely right there in the quality policy is like, and again, they don't have to be 2 separate documents. They can be woven together, but I think it's helpful to think of them in 2 contexts. But there's definitely a why in there for sure. And as we go through the steps, you'll also see, not surprisingly, there is a overview of what is happening now and what should be happening in the future. So does that explain a little bit? Excellent. Okay, thank you. Next slide. All right, just to remind everyone what the quintuple aim is. I don't know how far along we're going to go, but it used to just be the triple aim: improve population health, improve patient experience, reduce cost. For all of you providers out there, supporting the healthcare team we all recognize is crucial. And then the 5th portion, advancing health equity. I felt that a lot of the quality work is really aimed on getting to those aims. And that, again, using those attributes of simplicity, reliability, transparency, and efficacy are something to keep in mind as a strategy and policy are being built. Okay, next slide. All right, we're going to get into these kind of 8 elements. So it's not necessarily a linear process. It could be taken that way, but these really are sort of 8 different portions of a policy and strategy that are integral to making a whole. So if you go on to the next slide, this is all of them all at once. We will actually go through these briefly one by one, but I think what is really useful is it has, again, all of the different components, some which are going to be very familiar, some which will be a little bit less familiar, but really kind of make it possible to have this larger perspective, because I think it's One of the challenges of quality work is it's very easy to see a problem that is right up close next to us and try and develop a solution. And then, of course, that does make the system more cumbersome. Jim.
So probably the only thing in this whole document that I objected to was that second bullet, creating a local definition of quality. Do we really have a local definition, or do we just have local priorities in terms of where we want to go with quality?
Yeah, I think that's a great point. And I think it is definitely something that people would talk about. So we'll just start getting into it. So we'll go to the next slide. So again, starting off with, you have to have your goals and priorities. Otherwise, you'll be sort of chasing all of these separate quality metrics or goals. So this is an opportunity to have alignment across the state. It is also, you could build in the opportunity to have some region-specific goals based on that analysis and community input. But it is crucial, this really is the place where a quality policy and strategy needs to start, with these alignment of goals. So for example, this is not saying this is what would happen, but in the state of Oregon, the OHA has a strategic plan. The overall overarching state strategic goal, eliminate health inequities in Oregon by 2030, and they have their bullet points. And of course, it goes on and on and on about different ways to have a strategic plan, but these are just examples. But I think it's something that is crucial as we move forward with developing. We truly have a unified plan that ends up promoting that simplicity too and transparency. So next slide, please. So difference between goals and priorities. You can have large aspirational goals, but they do have to be clear. They should still be time bound. There has to be a way to assess the progress and attainment. And I think there is, a difference with priorities, which was what Jim was kind of bringing up. So priorities can focus attention on specific areas. It could be a medical condition. It could be a certain population. It could be a geographic region. So you could have statewide goals and state priorities, but then even regional priorities within that. And then, of course, there's always that balancing act of what has to happen acutely, but then also thinking about, and this is where we have the opportunity with the universal health plan, really thinking about long-term improvements and long-term goals and priorities. So kind of balancing those both. Next slide. And this is where Jim, I totally get your point. So that's why local is definitely in quotes. We don't want like 57 different definitions of quality. So using a standardized framework, and local could just be for your state. What does your state mean by, so the state of Oregon, by effective, safe, people-centered, et cetera. Or again, there may be a potential to have it be a little bit more regional, but definitely, and you'll see it throughout this presentation and in the proposal itself, really starting with a framework and then adapting it as needed, and in a very conscientious manner. So I wonder about your thoughts on that, or anyone else, of course.
So Mimi, it seems like what Jim was saying is actually correct. Like it really is about, we're agreeing on a standard framework, and then it's sort of local priorities that are aligned with that framework and not a true local definition.
Yes, I agree. And I think that it could be, maybe we can workshop that and come up with, this is taken from the workbook, but I agree, maybe not local definition of quality, but just create local priorities or something like that. Maybe we can work on that. Thank you. I really like that. Yeah. Next slide. All right, this one you get a 3 for. So this is 3 of the components all in one slide, because I think these are things that people are very familiar with. I substituted the word key participant for stakeholder. Stakeholder is a word that has been requested to not be used. It definitely has some negative connotation. So key participant mapping and engagement, that's no big surprise. That happens in almost any strategy or plan. Identify the key participants. I think one point that's very important is to develop those clear roles who are going to be the lead architects, who is the core team, how is this going to be created, this policy and strategy. Next, the situational analysis. So just what you were talking about, Jim, sort of what is the state of not even necessarily the healthcare system, but what is the state of your quality system right now? What are the required federal, state, and industry rules and regulations? What must you do? What quality measures must continue and efforts must continue? And then also importantly, which ones have been successful, have shown a change in outcomes or in other types of measures? Which ones have been unsuccessful and why? I think certainly within this group, people have had experience with both, or you could even have potentially a successful outcome, but the way that it was obtained was incredibly laborious and cumbersome and potentially even expensive. So, and then lastly, just having a clear organizational structure, making sure that the role of key participants is clear, and defining the authority and process by which the policies and strategies will be enacted and enforced, I think also is important. So in other words, if there is going to be, for example, quality, let's say upside risk or something. So yes, you get this benefit to a clinic or a region or the whole state. How will that be enacted? All right, any questions on these three? Those are the easy ones. Okay, next slide, please. All right, this one, I think I liked this quote: the most daunting challenge to safeguarding and improving quality, the judicious selection of interventions. So it is true. There are literally thousands of different interventions. So going on to the next slide. Not surprisingly, you want to start with a framework. So this is something I have never heard this pronounced. It's spelled J-U-R-A-N, so I don't know if it's Huran or Juran, but this is a framework that actually came from the business world, quality planning, quality control, quality improvement in that cycle, and it's been taken over adapted by healthcare, but really having a framework, a set of concepts and principles that you want to use to get to the goals of your policy. So planning activities, and then quality control, which of course we're very familiar with, and then the quality improvement activities. So again, kind of having this structure and building from there. So we can go on to the next slide. And these are examples. This doesn't mean this is how it has to happen, but these are different types of improvement methods and interventions. I think people are very familiar with these: harm reduction, improvements in clinical care, different types of engagement, or changing the system. So these are all different types. Again, now you can see why it's said it's kind of a meta approach to this, but being very intentional about the methods and interventions that are chosen in a particular quality strategy or policy. Next. All right, we're getting near the end. So I think this only has one slide. And of course, this could be a topic that one could go on for days: health management information systems and data systems. So clearly one is needed. Clearly a good one is needed. I think this came up again multiple times in the conversation, but the data has to be reliable. There has to be what people kind of refer to as the single source of truth. Some of the things that I think are important: clinical decision support and patient recording systems at the front line, making sure that those are effective and are working properly. And then of course, feedback systems. And it was brought up the New Zealand dashboard, their quality dashboard, which is phenomenal. So I put a link down there, but really this is where transparency can really be integral and can be built into the system. You know, in the dream world, you would build the system from the bottom up, and then be able to have all of the information that you want. Don't know if we're going to be as lucky as all of that, but this is sort of the goal, is that you will have all of the data that is required and being able to report it out for the good of patients and providers and the system as a whole. So one slide, big topic. Next slide, please. And then lastly, just utilizing standardized indicators and core measures. So you've got your framework, The idea is to use existing quality measures to the extent possible. I know Helen brought up, sometimes in Oregon, that's one of the things we like to do, is sometimes do things differently to achieve a different result. And that may be critical. But for the most part, usually trying to use what is already available can be very useful. And then using standardized criteria to help you pick which indicators you want to choose. So next slide. Oh, Jamie, please.
I just wanted to, in our excitement about standardizing something and creating a compliant system that's steady and predictable, I would also just want to call out, I didn't really see or hear anything about the potential for innovation or creating a way to support innovation in quality. Just wanting to make sure that's in there.
Yeah, I like that. Where I'm trying to think within, well, maybe we can talk about it, but sort of within the framework of that development, is that sort of continuous improvement, maybe kind of highlighting that in the area of continuous improvement, is that idea of innovation.
And maybe it goes into number 6, where you have improvement methods and interventions.
Yeah.
Call out specifically that one of the
I like that.
methods or interventions that we want to promote is
Thank you.
Local innovation that can be generalized.
I like that. Thank you so much. Okay, number 6. Thank you. Okay. I really appreciate that. Next slide. All right. Again, this is these are just examples. This isn't how it has to be done. Obviously, they're examples, but once again, going to that framework, either of quality domains. And this isn't, sorry, it's not always an either. Sometimes it's an either and, it's a yes and. So the quality indicators will have different parts of this. You could be looking at safety, and it could be a patient survey taken in a primary care office. So there's different parts to it. And these are certainly not the only ones. Again, these are just examples. The Agency for Healthcare Research and Quality, which is a national website, has a tremendous amount of information on these different types of quality indicators and core measures. Next slide. All right, these are just, again, standardization. I tried to put in all of the acronyms that to say what they were. People may be familiar with this. Certainly people perhaps have heard of HEDIS measures or CAPS measures. These are ones that physician quality is measured against, health plan quality, long-term care, et cetera. So again, these are happening mostly in the United States, but they are already in place. And there certainly are very valuable different types of measures that are within these. Perhaps not, certainly one would hope not to have the entire gamut. All right, thank you. And then next slide, phew, don't have to read this all, but when you're looking at those quality indicators, and I think this kind of almost goes back to Jim's, why are you doing it? What do you want? Is this a health priority? I mean, it may be fascinating on some level, but is this a priority? Is it evidence-based, and so on and so forth? But again, these are just things that one can use when picking out those quality indicators. So really, as I mentioned, and I think this might be my last slide. Go on to the next one. Yeah. So I think, again, the thought is to build this framework and a structure to build a policy and a strategy. It is not the policy and strategy itself. And I think that, kind of based on what this committee feels, whether this is something that's appropriate to go in front of the board and say, do you agree with this? Kind of with some of these differences, or sorry, with some of these additions like innovation placed in there. I will say one thing that isn't called out in there also is the kind of the financial aspects. I mean, it's inherent within some of it, but it's not called out. So that's a question to if people are interested in adding that to be a key component when it comes to proposing this to the board. So I'll stop now. Chunwei.
Thank you, Mimi, for a very thorough and comprehensive introduction and presentation. I have two kind of comments and suggestions that the committee may want to consider whether to incorporate them into this straw proposal. One related to Mimi we just mentioned at the end about costs. And so one of the core focus, I think the last one, the word efficacy can be replaced by efficiency, because efficiency incorporates effectiveness and efficacy, but adding a dimension of costs. And of course, later we can discuss what kind of efficiency are we talking about. Right now, I'm just focusing on the economic term, technical efficiency, meaning achieving the known outcome with minimum cost. The other efficiency is normative that require further discussion, the allocative efficiency. So we are not talking about allocative efficiency. We're talking about technical efficiency now. My second comment and question is related to in your slide section 8, talk about those different domain of quality. But in addition to those domain of quality, there's another facet of consideration. The pioneer in healthcare quality, Donna Bedian, proposed the 3 phases of quality. And I think the 3 phases can be interlinked with those 8 domains. The 3 phases of quality of care are: first phase is the structure or system, second phase is process, and the third phase is outcome. And each lead to the other. So the ideal structure or system is to lead to better process, and the better process is to lead to better outcome. And those are helpful not just in evaluating, assessing quality, but also very vital for improving quality. And so if we are serious about the quality of care, I think we need to consider from the basic, the structure system, to the process, to the final outcome. Thank you.
Thank you, Chunwei. And yes, I will say that the Dunabedian, that triad, it's sort of snuck in there on that conceptual framework under the phrase type. It says structure, process, outcome, but it's not really called out. So I think we could enhance that a little bit more. So thank you. In addition to the other thoughts of really thinking of efficiency instead of efficacy. So thank you. I think Jim and then Peter.
Well, first I'll comment on, I think efficiency and efficacy are different terms, and efficacy includes outcome and quality, whereas I'm not sure efficiency does, although there's an element of quality to it. But what I really wanted to bring up was I don't think the document emphasizes enough. I mean, it mentions it, but I don't think it emphasizes enough the importance of getting the buy-in of those people and institutions that are being measured. If you really want to be successful, the people being evaluated need to understand the process and the measurements and the tools.
Absolutely. Thank you. Yeah, that can absolutely be emphasized. I think it has like 1 or 2 lines at max. Peter.
Yeah, hi. Just to say, excuse me. Just to say, my favorite part is number 3 about participant mapping and engagement. Super important. I really love seeing anything that involves bottom-up feedback that influences these large systems, in particular, the unions of the employees who are doing healthcare. Super important to talk to them. Neighborhood associations, any kind of mass organizations, disability rights groups, things like that, undocumented individual advocacy groups made up of those individuals. So anything that really makes this a bottom-up system is great in my book. So definitely liked seeing that.
Thank you. Yes, absolutely. Kind of the emphasis on that. I think Eve, please.
I think this is a nice overall structure that's been put together. I would try to emphasize statewide standards wherever possible, because we do have providers who practice all over the state. And the more local variation, the greater the administrative burden for those particular practices. So I think local is good, and it will increase the burden overall. And we really should consider whether we will get the return that we're looking for on that choice.
Yeah, thank you, Eve. I'm looking. Oh, and actually, Jamie, why don't you speak? Because you put something in the chat. I think that talks sort of a little bit about simplicity things. So fire away.
Yeah, that exactly, Eve. I think that's one way to emphasize simplicity. I wanted to just call that out because this is a very, very thorough presentation and a high level. And ironically, it doesn't actually say anywhere simplicity in the document that I could find. And like, we're being super thorough, but a lot of our time in our discussion was really about, can we make this less onerous? Can we make it more simple? And then to your question on, this document doesn't talk about really the sticks and rewards, but we were pretty particular in our discussion that primary care should not have sticks. We should be given carrots and there should not be a downside risk placed on primary care in particular when it comes to quality. I think it's reasonable to have those sort of balances when we're looking at procedural specialties, when we're looking at hospital outcomes. There may be some need to put more skin in the game, and there has to be a downside risk if people aren't delivering quality care. But I think enhancing the upside is part of how we deal with creating access by drawing providers into a state who want to do something where they can do their best work, where it's rewarded, and they don't have to submit 47 different quality metrics.
Absolutely. Thank you, Jamie. Tony.
Yeah, I really appreciate Jamie's comment there. You know what? I think quality, there's multiple domains of this. It's whether, a medication is given appropriately by a medical assistant, whether the cleanliness of a facility, and we have a whole litany of these things. And I think that, and then we also have this consideration for value-based payment, which is, trying to return on population health and the quadruple aim with that. I would just like to echo, and not to be redundant here, but simplicity in the system as far as where quality is, making sure that appropriate care is given in the setting of a hospital. We have these systems like JACO. We have these systems that are evaluating clinical in an outpatient setting as well. I could see some consolidation of that. And I think maybe the entity that was drawn up as far as being creative, that we have all these multiple different spaces, but there isn't a ton of overlap in some of these sectors. And I think that innovation, creative space could coalesce some of those so that you don't have this panoply of different things going on, right? So just to call out simplicity, leveraging what's already existing, working well, not redoing it in this system we're creating.
Thank you. Oh, great. Angela.
Hi. Yeah, I just want to echo the importance of having meaningful quality incentives as well. It's interesting. I kind of thought, I don't know, I was a little bit blind, I guess, thinking that everyone focused on quality. And recently we kind of merged cultures with some other clinics, and it was kind of shocking how little data they collected around quality and others. So I do think, those incentives do drive a lot of work and focus. Agree with the simplicity though as well. And it seems like if we're looking at a New Zealand type approach, they're collecting a lot of data, but perhaps you're incentivizing certain levers at certain times depending on the outcomes that you want to see. So that could be an approach in the future. But yeah, overall, appreciate the thought and consideration and agree with Jenway's comments around the structure, process, and outcome as well. And again, incentives could be around where we are seeing issues or disparities, et cetera.
All right. Well, I feel like we have a lot to take back and certainly not change everything, but I think there's enough that I would rather bring back kind of with all of this amazing feedback, revised, revamped, zhuzhed up proposal for this committee. And then sorry, board, it will be a little bit later, but I think it's well worth it because I think these are just, it's crucial input that I really appreciate. I want to make sure that we get it right. So do you feel okay about that, Chair Blanca?
Yeah, absolutely. Yeah, I think that's good. And we can plan to, bring back a revision for November. And yeah, that's a good idea.
Oh, great. And Betsy, you have your hand up. Pardon me for not seeing that.
Yeah, no, I literally just raised it, and I think I feel like I'm doing the one more thing while the doctor's walking out of the room. But one thing that's occurred to me lately that I think we really are missing in our quality frameworks that we're using currently is measuring the health of the system and how the people who work in the clinics are doing. What is the stress load? What is the burnout? We don't have a way of measuring that. And I think that's incredibly important. So in as much as we are thinking about quality, I mean, that goes to one of the parts of the quadruple aim, but I've been thinking about how do we measure the health of our healthcare system? And I feel like that would be an important piece to factor in here.
I love that. No, I really appreciate that because it's true. Part of the quadruple and quintuple aim, and yet you don't really see a whole lot about that, do you now?
Does anybody measure that? It's such a good point, Betsy. Are there systems that measure it? Does anyone know?
When you think about it, who would do it, right? If it was an insurance company, like how you doing, Smith Clinic? Are you going to say we're dying under the measures you've piled on top of us? Please stop. Like, because I think the risk factor of being candid about that kind of phenomenon in healthcare is still quite large. So it's on my mind a lot, and I'm talking to people about it. That we need to better understand how we're doing, what all of this that we're asking the healthcare system to do means for the people in that system.
Yeah, I'm really glad you brought it up. If you hear of anything or get an idea about how to do it, but yeah, we should definitely build something along those lines into this proposal because you're right. That's kind of why we're all here. We're all, I mean, in some ways, there's just a lot of frustrations with the healthcare system from every point of view, from people accessing healthcare to people providing healthcare. There's just a lot of frustrations, and so getting at it from both angles is great. Thank you.
Eve.
I would just say that there are some proxy measures for that. There are some real measures too, like there are healthcare burnout questionnaires that you can do, a sample size that might be statistically significant over a period of time. But the proxy measures that are easier to gather on an ongoing basis are things like turnover rates and vacancy rates. And there are organizations that gather these types of data, and you can do it by type of clinician. And then, there are some other proxy measures that might implicate provider burnout in some settings. So things like caseload volumes or panel sizes are examples of that. Appointment lengths. So there are things that you can kind of do to drill down on what we know burns people out, which is the hamster wheel and moral injury. So I think there are probably options there.
That's fabulous. Thank you.
And Jamie.
One of the other measures I've seen used for this in my current practice and in the university that I practiced in was the Gallup survey. So the Gallup Q12 engagement. And again, if we're doing the same survey system wide, it's a very simple, it's 12 questions. So it's not overly burdensome. And I would say that maybe this is another place we might request simplicity, is that we might include a recommendation to explore something like the person-centered primary care metric as a measure of patient experience rather than a 39-item MGMA survey. So, like we might make some examples of ways that this could be looked at in a more simple fashion.
That is great. I love that idea of very clear examples. Thank you all so much. I'm really excited to get to do this.
Excellent. Anything else on this topic?
I think Jim has his hand up.
Ooh.
So this discussion is just kind of reminded me, I guess is the way to put it. You know, one of the things I talked about was the connection between what you're measuring and action and what action you take. And that's not always immediately apparent. And the comment about turnover, I'm reminded of a story here in Maryland. We have global budgeting, and one of the hospitals was telling this story that in order to reduce readmissions, they had a long-term, some kind of long-term care or rehab facility, basically across the parking lot from the hospital, and people were getting transported by ambulance from one side of the parking lot to the other, and this was counting as readmissions and counting against them. So, in order to reduce readmissions, they implemented a telemedicine program. And one of the side benefits of that was they discovered in the 4 years before they implemented this program, they had 3 medical directors. They had huge staff turnover, but by allowing the people in the rehab facility to be more engaged in the care of these people, they reduced turnover. They were able to keep a medical director for several years. But had you just been measuring turnover, you wouldn't have drawn that conclusion.
Yeah.
It's just kind of
yeah. It's a really good point. What action will you take? Like building into the quality strategy I don't know what it would look like, but
no, I don't either, but
but like something about like what do you do when you're measuring this? Like what do you do about it, or how do you reintegrate it into the system to actually improve things? Yeah. Did I miss anyone else? I can't see anyone's hands. I'm sorry.
Yep, I think we're good.
Okay, let's take a break. It's 2:25. We'll take a 10-minute break. We'll come back at 2:35 and talk about hospitals and behavioral health. Hi, everyone. Welcome back from the break. We're going to get started right on time here because we are lucky enough to have Cheryl Ramirez joining us. She's the Executive Director of the Association of Oregon Community Mental Health Programs and a member of the Universal Health Plan Governance Board. And she's going to be participating in the discussion and presentation. So take it away.
Thank you, Helen. I'm going to hand it over to Mimi until we're talking about the public behavioral health system. So go ahead.
All right. So apologies, people, that you get me twice in a row. I should have planned the agenda better, but here we go. I am briefly going to review just a quick recap about what the Joint Task Force report recommended, what your own straw proposal draft has looked like, and then we'll kind of go on from there. So really focusing more on the payment systems than on the benefit itself, but kind of moving from there. Okay, first slide, please, or next slide. Great, thank you. So again, from the Joint Task Force report, kind of exactly what we were talking about earlier today, that behavioral health benefits would be influenced by the Oregon Health Plan, which actually is more flexible than, say, the PED plan. It has a wider coverage of mental health benefits. And the task force designed the plan to allow for additional funding for behavioral health with those funds realized from administrative savings. And then within the straw proposal draft, which was created by this committee, again, that discussing this expanded behavioral health coverage, which I'm hoping that we will be able to drill down a little bit. So the plan would mirror current Medicaid coverage. And what we are going to talk about is where some of these services, where they are covered and how they are covered through state funds, through federal funds, counties, et cetera. And really try and start, there's no proposal at the end of all of this, but really just a discussion. So just to set the stage. All right, next slide, please. All right, so again, this is from the work that you all did talking about the different types of proposed services. One thing that I wanted to be clear in my own mind is that these proposed services that are on the list is that these services would be available to anyone who is on a universal health plan. So that is actually a genuine question of mine. Am I correct in that assumption? But anyone who needs these services, obviously. Cheryl.
I just wanted to chime in here because I was originally on this committee and I worked on this list of services that isn't covered by commercial insurance generally. And these are really public behavioral health system services. They're funded a lot differently. And I don't think this will come as any surprise to any of you in this group that Medicaid is the best payer, the biggest payer of the public behavioral health system. They cover many of these Medicaid covers many of these services through CCOs here in Oregon. And the rest is really, the gap is filled through state general funds, which include federal block grants, and some, other federal grants, some burn funding, if you're familiar with that funding. So just wanted to mention that here, that these are more public behavioral health system services, and there's only a very small population that will need, let's say, pre-commitment or aid and assist PSRB services. So that's like the top of the pyramid.
So Cheryl, are you recommending that we limit some of these services to the OHP population only? Or are you just saying it would be okay to offer them to everybody because probably only a small percentage of the population would use them?
I'm not sure what I'm saying here. I'm just saying that there are very many people who will use some of these very high-end, intensive, acute services, but for those people, those were costly services. And so I think it kind of goes along with whether or not you all are talking about covering like Oregon State Hospital services with this benefit plan, which is the most expensive behavioral health service there is. I think it's kind of along those same lines with some of these.
Got it.
Thank you. That's very helpful. And Eve, I saw your comment that some of these are Medicaid only. And I know we're a little bit short on time this time, but I think that is definitely a topic that we'll want to get more detail on about the consideration of this committee. But for right now, we'll just go on to the next slide. This is a list of the provider types, and we do have a couple slides in here which show. So here is all the provider types, and we coming up there are a couple slides which show which payers pay for which types of providers, because obviously certainly not all commercial plans certainly don't cover payments for all of these providers. So again, this is what came from your committee. I'm going to go on to the next slide. And now I'm turning it over to Cheryl.
Okay, yeah, and I can just say, this is a visual of a lot of those services that you had listed in the other chart. We call this our rainbow chart with prevention, the least intensive services to the left in purple and the most intensive and most expensive to the right in red. So that this is really the continuum of care for the adult behavioral health system. And as mentioned, Medicaid is a big payer of these programs, but I just want to note that some of the services provided here, even for Medicaid clients, are not Medicaid eligible. And that's when you get into clients who are involved in the justice system, or if they are at the state hospital, they're in an IMD, Institute for Mental Disease, and that is not Medicaid reimbursable either. So there are some services here that even Medicaid doesn't cover. That's all I've got on this one.
Thank you.
And then this is the child youth behavioral health continuum of care, kind of the same setup, least restrictive on the left, most restrictive to the right. And what I would say is children who are covered by Medicaid have much more robust behavioral health benefits than children with commercial insurance. That is a solid fact. So again, these are services that a lot of commercial insurers don't cover. And part of it is because, as Mimi mentioned, the provider type, and part of it is just like the team-based care. It's really difficult to cobble together the billing codes, you know, to make that work. That's all for this slide.
All right. This is another one of those recap slides. So from going through the notes and the committee proposal, really just trying to pull out what it seemed the committee had an emphasis, of course, on community mental health, school-based services, integrated behavioral health and primary care, crisis coverage services, stabilization centers, also case management and peer navigation, and then also because and maybe one of our providers out there can talk a little bit more about this, about case management and peer navigation being able to happen before a full assessment, which I think is a sticking point. Okay, we'll go on to the next one. So this pie chart is who pays for behavioral health services. This is a national pie chart, as it were. So this includes an entire population of the United States. So as you can see, however, 58% of it is covered by, what would be considered public funds, so Medicaid and Medicare. Only 34% covered by commercial insurance, and then 8% out of pocket. So this is everyone all together all at once. But if we go on to the next slide, and Cheryl's going to talk about this one.
Yes, I thought it would be helpful to show the contrast with the public system. So like I mentioned, Medicaid is the biggest payer. So out of the total, about 60% is Medicaid funded. And out of that 60%, here in Oregon, 90% of that funding comes through coordinated care organizations, and about 10% are direct fee-for-service contracts with the Oregon Health Authority. Our second biggest payer is the state. So we have contracts with the Oregon Health Authority to pay for a whole bunch of things on the rainbow chart with that funding. And then as you can see, the remaining 10% is just a combination of things. The larger counties may pitch in general fund themselves, not very many. The burn funding, that is, as you may know, is the marijuana tax revenue funding, and it cannot be used with federal funding at all. It's got to be very separate. And then some federal grants, and then lastly, commercial insurance, Medicare, the VA, and they are the smallest payers of public behavioral health services. And again, it's because of the provider type and the team-based care.
And on the next slide is saying that just in a slightly different way. So you have like the different types of federal funding, SAMHSA in the form of block grants, of course, Medicaid funds. And again, Medicaid is the single largest payer for behavioral health services. There are HRSA grants, other grants, veteran support. And then of course there's state funding. So which I think is fascinating. So if you look at it, we've got the general fund, but there's also lottery funds, those hospital provider taxes and insurance, tobacco taxes, marijuana, beer and wine. So it is very much a patchwork system. Some of the counties, although I think, Cheryl, that was really helpful to see pan out there. I mean, there are county funds that absolutely go into it, but it's a pretty small percentage. And then, of course, private insurance and out of pocket. And so if we can go onto the next one. So these slides are taken from a OHA presentation to the Senate Committee on Early Childhood and Behavioral Health. So this was in January of 2025. And we don't need to look at them in tons of detail. The gold, in case you can't see the blocks, I apologize. The gold stands for federal funds. The dark blue is state general funds, and the green is other, which is not completely called out, but is sort of that mix of other funds that we were talking about. But I really think the important thing is just that increase, which in some ways is really good. We wanted to increase behavioral health spending. Some of this is very intentional and not necessarily a bad thing, usually when we think about spending in healthcare. And then again, if you look at it, now this is OHA, the whole behavioral health systems budget. It's about 50-50 between state and federal funds when it comes down to it. Oh, please, Cheryl, yes.
I just want to note that this big increase, 21 through 25, had to do with post-pandemic funding. There was ARPA funding and CARES funding, if you recall. And so I think those substantial increases, they were well, for one thing, they're one-time funds. They're not going to remain. And I believe we'll see a pretty steep decrease in this next biennium, unfortunately, because of all the federal policy factors.
Oh, that is very helpful news, and we should be able to get that information if it's not already out there very shortly about the 25-27 estimate. Rosemary, please.
Hi, do we know, so this is funding. This is not utilization. So utilizate is that correct? Is this just funding costs versus utilization?
Yes, that's just funding that they provide and how it's broken out. Yes.
So do we know if utilization also increased at the same rate as funding did?
That's a good question. I know utilization increased for sure. That's why, well, that's one of the reasons why we're having issues right now with funding challenges from CCOs. So I know it increased, but I don't know if it increased proportionally to this chart.
Yeah, that's a great question.
And in thinking about one of the slides going back, I'm thinking about prevention, right? How much are we actually putting into prevention versus actual treatment?
I believe it's less than 1%.
Yeah.
Would love to put more resources into.
What does prevention look like as it relates to prevention around mental wellness, right?
Yeah, absolutely. Oh, Helen, please.
Cheryl, I know that, part of the investment in behavioral health has been to make more services available, but I also know that the workforce is grossly underpaid. How much of this increase in spending was to improve compensation for the workforce versus just increased services?
I don't know the percentage, Helen, but it was definitely a major priority. And the 30% behavioral health directed payment through the CCOs went towards the workforce with, to be honest, some mixed results. But I can tell you from the public behavioral health systems perspective, this has helped a lot. We were having a workforce crisis during the pandemic and after, and just being able to pay people more, give them incentives, for staying in the public system. Those include like educational incentives to get their masters, let's say, or housing or childcare bonuses, that kind of thing. That helped a whole lot. And we're seeing the workforce gap narrow a bit. We still have a ways to go, especially in very difficult areas like crisis response is really hard area to work, and some of the forensic and involuntary areas it's hard to keep people there. but it's getting better.
Good.
Oops, Rosemary, please.
Yeah, so just to clarify on that, so when we look at these numbers include spending on increases in reimbursement to behavioral health providers, retention programs. I know OHA had a lot of those. There's also the student loan for behavioral health repayment. So that is included in this budget as well?
Yes, that's everything. That's
That's behavior.
that's direct services, that's workforce investment, that's even facilities, residential facility investments, which were quite high in this time period.
Okay, thank you.
Thank you both for those clarifications. If we want to go on to the next slide. And again, apologies for how small this is. And Rosemary, your point, if you look at a public health prevention, you see there, Cheryl nailed it, less than 1%. And this is the funding by program. So mental health being at 70%, gambling less than 1%, alcohol and drugs 16%, and then the Oregon State Hospital at about 13%.
Wow.
Yeah. Yes.
I just want to quickly say that the Oregon State Hospital is 13% of the total behavioral health spending. But if you would look at just the state general fund, it's more like half of the state general funding. So that's a little, in my opinion, the slide's a bit deceiving in terms of the resources that the state hospital uses. And believe me, I mean, we need the state hospital. I'm not saying that, but it takes a lot of the state general fund for behavioral health services.
Half of our state general fund pays for the state hospital.
Half of the state general fund for behavioral health.
Behavioral health.
Oh, okay. The component of the general fund that's for behavioral health,
right.
Half of that's used for the hospital.
Yes.
And we don't have enough beds.
That's right.
Wow, thank you. And then next slide, which I think this might be one of yours, Cheryl, that I stole.
It is. I wanted to just say something about these next, I don't know, 2 or 3 slides. This is something I prepared for the Joint Task Force at that time. It was in 2021 to help them understand how behavioral health system and how the providers were reimbursed. Because I thought that would be useful as we were coming up with a plan and we were thinking about setting aside funding for the behavioral health system. As you can see, just fairly narrow provider types are reimbursed by the VA, Medicaid, Medicare. At this time, Medicare did not even reimburse all of the licensed behavioral health clinicians. In the meantime, they've started reimbursing LMFTs, licensed marriage and family therapists, and licensed professional counselors. So that's new, fairly new within the last few years. But all of the unlicensed professionals, they are not reimbursed by insurance, with one exception. There's one insurance carrier who does reimburse unlicensed QMHPs and A's if they're in a certificate of approval organization, like a community health program, let's say. So there's one exception there. But otherwise, we're really reliant on Medicaid to pay. And in some cases, state general fund goes toward especially peer support specialists.
Can I ask a quick question about that? So do the unlicensed clinicians, do they provide services for everyone regardless of payer, but they're only getting paid by Medicaid, or they can only provide services for Medicaid?
They can provide services for Medicaid, uninsured, Medicare clients often use the public behavioral health system because Medicare is such a poor payer that when they have significant behavioral health needs, they do go to the public system, and so they are seen by unlicensed clinicians. And I would even say underinsured underinsured people with commercial insurance. It's just that we could never bill commercial insurance for their services. Like, we have to pick and choose the billing codes that we can bill for. Or in some cases, just as an example, when it used to be that Medicare only reimbursed LCSWs, some of our public entities would just assign an LCSW to all of the older adults that they served so they could bill them, for some of the services. So that's kind of the workarounds you have to do, to even bill it all. But it's, as you saw the pie chart, it's not much. So really what's happening is, in those cases, state general fund is subsidizing commercial insurance and Medicare.
Okay.
Yeah, and if you'll go on to the next one, Isabel. Again, this is a little bit more of the same.
Yeah, it's really, it just shows you all of those services that you had originally listed, how they're reimbursed, and you can see that it's mostly either state general fund or Medicaid for the most part, most of the services. And it's just really either the acute, psychiatric care, very kind of general therapy, outpatient therapy, and some residential. And that's all I've got on that slide.
Yeah, and then the next one.
And this goes to the billing codes by services. So all of those, again, all that list of services, you can't bill for them. So therapy you can, the assessment, medication management, you can bill for that. Hospitalization, we don't have that on there for some reason. So just another way of saying the same thing, basically.
Yeah, well, I know Cheryl has another meeting. She was a hot commodity, but we'll save all of our questions for you, Cheryl. I'm
I
so
don't know
grateful.
if there were any other slides that I had put in. No?
I think this was it.
Okay, all right, thanks. Yeah, glad to follow up.
Thank you so much, Cheryl. We really
Thank
appreciate you being here.
Yeah, sure, of course. See you.
Yeah, that was so helpful. I will just confess, I was picking out slides along the internet, and I said, I know who made these slides. So that's how we got so lucky. Again, I think this is already on another slide, but these are just different ways for outpatient payment system, very similar to other kind of payments, as we know, just for other health services. So we can go on to the next one. And I don't want to necessarily spend time on this, but there is more and more sort of these alternative payment models for behavioral health services. I know Cheryl has spoken in the past too about the certified community behavioral health clinics, and we heard about that too. And a lot of bundled rates that enhance fee for service. So those specific billing codes that are available for team-based activities. And then behavioral health homes, some per member per month, some capitated payments potentially that are available. And so again, this was, as I said, this wasn't really a proposal at all, but really just setting the stage for the discussion that you previously had, kind of a state of the state, as it were, right now. And then next slide, please. I just put in a basic goal, and then we do have another slide after this with some committee member input already. So I don't know. Sorry, if I put Peter and Rosemary on the spot a little bit, but this is from them. So I don't know if either of you would mind talking a little bit about what you had written.
Yeah, I wrote this months ago, so I don't
I know,
honestly
I'm
remember
sorry, that was a little
the thought
that was a little
process that went into it, but But so a hybrid approach, I think that so as your presentation really highlighted that fee for service is not good enough. Like there's so many complicated things where there's team-based payments and all of that. So if it's more capitated or if it's salary based, we need more diversity in payment, I guess. Although, adding complexity then it's not something that we want to do unnecessarily. We want things to be simple and streamlined, but having multiple like ways to pay for behavioral health seems to be needed. And I don't know if our plan or if the governance board really has a say in this or how much weight they can put on this, but I think the evidence clearly shows that community controlled health cooperatives, worker co-ops, situations where the employees have a greater say in how the business is run, those businesses do better than when it's a traditional, top-down capitalist model. So that's better quality of care, that reduces turnover, which we were just talking about earlier. So to whatever extent we can emphasize co-ops and cooperatives somehow, that would be great. And what else? Oh, we were talking about that. Yeah, right now it's really weird that so if there's I'm an outpatient right now. I've done, inpatient and community stuff in the past. Nowadays I'm an outpatient. And so I see a client for 60 minutes of therapy and I get reimbursed at a certain rate. A psychologist providing the exact same service gets reimbursed at a different rate, or an intern or a QMHP or whatever. And that just, in my opinion, we should stop that. It should be paid, it should be the same for the service that you're providing, regardless of the educational background or the degrees that you have. I think that would be helpful. And yeah, more emphasis on traditional healthcare and traditional healthcare, community care, mobile care. Well, yeah, that's those are my ideas.
Thank you. I didn't know, Rosemary, if you wanted to add anything to that.
I concur.
I love it. Yeah. All right. I am now going to turn this over to Helen. So to kind of move along in the discussion. And I think these are some of the questions I had about scope, but Helen had some specific ones. So off to you.
Yeah, thanks. So I think what we're dealing with, we've got a lot of input in the beginning from this committee about what our intent was. And that's been really helpful. But as we dig into the weeds of it, just like our earlier discussion, we're realizing that where the money comes from is really complicated. How services are paid for is complicated. And then what keeps being brought up is this idea of we have different provider types in Oregon, some of whom are unlicensed and therefore have difficulties getting paid by certain payers. It's just a complicated, fragmented system. And my understanding is it's a remnant of the fact that historically, decades ago, we separated mental health and substance use disorders from healthcare, that they were considered sort of social problems and not really part of your health. And luckily, that idea is changing and evolving. And we understand now that mental health and substance use disorders are part of the overall concept of providing healthcare for people. But we're left with this system of very fragmented funding, a lot of which comes from the general fund dollars or from grants, right? So it's complicated to pull it all together. And so when we're thinking about how we would integrate all of this into a universal health plan, we just wanted to get a couple of things sort of squared away. And first of all, is it our intent to provide all services currently only paid for by OHP to all Oregon residents? This was my question to Cheryl earlier. Do we want to reserve some services only for those who would otherwise qualify for OHP? And again, we're already doing that. There's a number of services that only OHP folks would qualify for. So we could add a few of these behavioral health programs to that. That would be really consistent with what we've done before. Or is it the idea that we should make behavioral health services available to everyone? That would be the first question. And then second, should the state or federal behavioral health funds that we get from like state general fund or from federal grants. I'm not talking about healthcare dollars. I'm talking about sources outside of healthcare. Should they be incorporated into our healthcare dollars, or should they be kept separate in terms of a behavioral health fund at the state level? And then would this committee consider recommending a model of a global budget at the state level, dispersed to global budgets at a regional level? One of the ways to sort of break up the fragmentation to accommodate providers of different licensing or being non-licensed and different educational levels is to just give a region a global budget and say, this is your role is to serve the people of your community however you see best. Here's a global budget that will grow at a certain rate each year, and you are in charge. You can figure out, how best to serve the folks in your community without all of the reporting requirements and data requirements. And we can give people this coverage because they have this insurance, but we can't give it to these people. So it would just be like a single global budget for healthcare. So those are kind of the questions that I came up with. The idea here is that we want to sort of modify our behavioral health proposal. It wasn't very specific before, and it didn't tackle any of these funding questions. And so we want to modify it and try to capture the direction that this committee thinks we should go. So I'm open to any feedback on any of these questions here.
Eve has her hand up.
Thank you, and apologies I can't be on camera. It's my turn to pick up the kids this afternoon. So I think either some of the supports are limited to individuals who would qualify for Medicaid, or another way to do it would be to add as much as this is sometimes seen as a dirty word, but prior auth requirements. So, you only need ACT services, or you only need residential housing supports if you have a very significant behavioral health disability. So it could be that in our system, anyone would qualify if their disability reached the level required for those services. So I think that would be another way to look at it rather than it just being income-based. I do think we need to look really closely at the mandated services. So if half of the general fund that goes into behavioral health is going toward mandated services, those are generally court implemented, and they are, as I say, mandatory for people to participate in. And is that something that we want? Do we want our healthcare system, paying for that type of care, or do we want to leave that in the general fund? I think there are arguments to be made for both. It could be that whatever we do with the jail system, we would do with this system, except we had talked about with the jail system that jails would pay into this, so that we're not just displacing the cost onto the health insurance system. And I think that's harder to do from the state general fund. So anyway, I just think that's a complicating factor, and we should have more discussion on that.
Great, thank you.
Oh, Mike has his hand up.
Thanks, Mimi. So I just want to make one comment. I don't know if it really kind of. My understanding is a lot of the financial challenges CCOs are having right now is related to behavioral health utilization. So I am a little, I don't want to say concerned, but I think we need to have eyes on what happened with them, because my worry is if we're basing a system on OHP and then that system is potentially collapsing because of increased behavioral health utilization, assuming that's true, but that's anecdotally what I've read. We need to be very careful about that. And what got me thinking about this was actually Dr. Hemming's questions earlier when she saw the funding was asking about utilization. Well, I imagine utilization actually did go up, but you also saw the funding went up as a result.
Yeah. Yeah. Thanks, Mike. Yeah. Anyone else with thoughts on this?
Too, if people have thoughts about like specific types of information that would be useful, like Rosemary Hemmings, that you were asking about, well, utilization. So like that kind of data, and you don't have to come up with it right this minute, but as you're thinking about this, so we can do some more research into some of those specifics, like as you were talking about, like the mandated services,
Yeah,
et
I would say
cetera.
what proportion of our behavioral health payments are for mandated services? That's a really important thing to call out. Yeah.
Or when we see that cost data, um, if patients are being evaluated, if they're being triaged for mental health issues in the emergency room, are those costs being counted in these figures also?
I
No.
don't think so.
Okay.
I mean, I might be wrong. Someone correct me if I'm wrong, but I don't think so.
I'm not certain because I think I've seen some data in the past where depending on what the when we were looking for some of this data from our CCO for our integrated program, that it seemed that they did have some ER related codes that were specific to psychiatric or mental health diagnoses that they were counting those or including those, but that may not be the same as where these figures are coming from. I just wondered because I think in terms of like cost savings and utilization, like part of the utilization assessment has to include not just utilization in traditional mental health settings, but there's extra utilization for patients with untreated mental health disorders that's getting done in the most inappropriate and expensive of places.
Yeah, absolutely. In fact, I keep hearing this quote from folks at HealthShare that there's like 5% of their population that's using 40% of their services, and it's almost exclusively around mental health and substance use disorders. Spending, like a huge proportion of their budget. Yeah, and then Rosemary also mentioned Unity. There is a psychiatric emergency room and inpatient at Unity, and that might be what that represents. I don't actually know, but I feel like if they're in the emergency room, that's getting counted under physical health costs, but I can't be certain on that.
And Jamie has her hand up.
Thanks. I feel free to say thank you, Captain Obvious. It feels to me like we're having a parallel discussion around behavioral health funding that we had with primary care funding, and saying that primary behavioral health, preventive care, needs to be covered in a different way that's capitated and separate from hospital costs and ambulance services. So we've had this discussion around primary care and uncoupling the payment structures and saying that different payment structures needed to really support the primary care needs. It feels like a very similar or parallel discussion that we're having now around behavioral. And it's lovely because it is a bit of a revolutionary moment to say, fee for service, and then trying to restrict who can do what, how many times, what office, with what title, and trying to manage that is not tenable. It doesn't work in primary care. Why do we think it's going to work in behavioral care? As Peter was suggesting, if we can give the health, the maintaining of mental health responsibility to a group in a region to figure out how are we going to put the services around these folks to give them the best possible outcomes, that can't be linked to the hospital cost. Has to be separate in order for that system to be sustainable, I think.
Yeah, that's a great point.
I mean, and just the PS of that is that's what FQHCs have been doing, and it works. We throw behavioral health integrated and there are still some pinch points where, you know, certain people can't bill for stuff, but the idea of treating behavioral health care in the setting of primary health care and paying it similarly works in FQHCs. And
yeah, that's great. Yeah, that really helps to think of it, building it parallel like that. Yeah.
And Tony.
Yeah, just to piggyback on that, I mean, my own clinic system is embedded warm hand up method for behavioral health for over a decade, and we have a mental health prescriber in there, and it is just really a productive environment for the staff to deliver a holistic approach. I think we do deliver very well on health outcomes and that preventative model. And collaboratively with the community where we can't meet those needs. I do like the idea of a global budget and letting areas be innovative and creative and augment that. I think Mike's acknowledgement, or just not acknowledgement, so much concern about the total payment. You know, I fundamentally feel like we need to expand behavioral health services. But you know, in doing that in this system right away may not be the right answer right away, but having space for growth and understanding that is a great return on investment. So, you know, that's in essence what would be helpful for a global budget, is to control costs with that, with an intentionality, expand perhaps that growth for those services.
Yeah. So we have one more item on our agenda. Are there any other comments on this before we move on?
Jamie has a hand up.
Okay.
Thank you. I just wanted to call out one potential pinch that I'm, as Eve commented before, I'm at the edge of my understanding of this. So please, if somebody else has better understanding. I think one of the pinches currently when we have regional and CCO coverage is that patients with mental health issues may be mobile and be changing regions, and we want to not disincentivize coordinated care if a patient changes or crosses a county line and suddenly finds themselves starting over. And so there's been sometimes regional coordination creates unnecessary barriers to care. And a single payer system should be able to obviate that, not make that worse.
Yeah. Okay, thank you. Okay, let's switch gears a little bit. I'm going to hand it over to Lee Hastings to talk about hospital payment, and then we will wrap up.
All right, and with any luck, I won't actually be doing very much talking. The goal for this is really to kind of have a guided discussion, poll session. I'm going to be trying out the use of an interactive tool, so we'll see how that goes, but really looking for a sense of how people are feeling about hospital payments and allowing us staff to then bring you a preliminary proposal soon. Next slide. So this is the context, should be familiar to everyone. Of course, the Joint Task Force issued the recommendation that a universal health plan should use global budgets or other alternative payment arrangements that are really focused around value. And then the Universal Health Plan Governance Board statute, which is under that ORS 751, defines the single payer healthcare financing system, which is what the board is charged with looking at, developing proposals around, would pay institutional providers with global budgets. So it doesn't mean that's what has to happen, just means we are obligated to, of course, take a look at that. And we did present on that in the past, overall hospital financing as it currently exists, as well as a little bit about how global budgeting works and has functioned in some other areas. Next slide. All right, so our goal today, as I mentioned, it's really to establish that framework for a preliminary proposal on hospital payment. We are looking for progress here, not perfection. So just knowing that we want to start getting something down on paper that we can have first you all and then the board react to, but it's going to continue to be an iterative process. Also hoping that today's tool will help us identify some areas where we have really strong consensus and areas that maybe we as staff need to explore and present a bit further on. This quote, I happened to find it looking up different sort of management decision-making tools as I was doing some research for how to lead this. And, you know, think whatever you want about Jeff Bezos. Does have a successful company though, but I did really like this idea about decision making that if you have 70% of the information, you're ready to decide. Just essentially noting we're never going to have all the information we want, especially you know, in an environment like healthcare that is just so complex and ever evolving. But there has to be a point where you decide, you know, you have enough and it's time to move forward. So we're going to see how far along we are. Next slide, please. Okay, so just a preview of our discussion. I have actually about 10 questions, but these are the main areas. We're going to have just a couple questions in each of them. So a couple questions related to what you think should be a predominant payment methodology. We're then going to ask about different hospital types and who should have exceptions maybe, or who should have special consideration. A couple different questions on the components of a global budget, and then a couple questions on transition factors. These are high-level questions, but hoping to, yeah, really see where members stand on this. And next slide, and then we're probably going to need a minute to get set up here. So I'm going to put Isabel on the spot a little bit. Isabel, I'm hoping you can send everybody, there's actually a direct link. It should have this rootofmenti.com. And I'm going to ask folks to follow that link because that's going to provide a way for you to do this sort of interactive poll. If you're not able to do it, I will read through the questions and the answers. You can always call out your answer. But if you are at a computer or at your phone and are able to participate this way, I think that could be really helpful just because we don't have a whole lot of time and there are several questions. So I'm going to give folks a minute for that. And Isabel, if you could let me share my screen, that would be great.
Yes. So committee members in the Zoom chat should have just gotten a link to Lee's activity, and Jamie and Max K. Zoom, of course, needs to get mad about something. I emailed you the link because it just didn't want to cooperate for you two. But if anyone has an issue, let me know if you're not seeing that in the chat.
Chat.
I think I have it yet. The last thing I have is from Gabe.
It'll be
other
a
people have it?
separate chat from the main
Ah. Oh.
Where?
Aha. It says Isabel plus.
There are different chats. If you're on the chat thing, look up at the top for a different tab.
Oh, okay.
Yeah. Awesome.
I'm trying to share. There is a little warm-up question. I apologize. I'm trying to share my screen and it is offering me the option to share every application except for my web browser. Oh dear. All right, well, we're gonna make this a little complicated here. All right. Not that. Not that. Oh goodness. Okay. I am just not sure how to get this to work right. What are folks seeing? Because I just see all black right now.
Yeah, that's what we're seeing as well.
Let me.
Well, then you can always report out to Lee just kind of what the results are, because you're getting them, correct?
Yeah, I'm hoping to, let's see. Okay, I'm gonna try this option now. Good grief. Okay.
No, it's still the all black one. It worked earlier today. Shoot.
Yeah, that was on Teams. I don't know why it's not letting me just share my web browser. That's really
okay.
All right. Well, I apologize for that. That is really disappointing. But let's see. So we've done this intro activity here, and it looks like fall's actually our winner. We've got 5 people there, 4 people under spring, and 3 for summer. Nobody's a fan of winter, apparently. All right, so with that, we are going to try to get started. Okay. So our first kind of question related directly to our topic, what should be the predominant payment methodology for Oregon acute care hospitals? This is a ranking question, so you can rank them 1, 2, 3, 4, 5. If there's only one that you like, you can just put in 1 and submit your answer at that point. If you want to rank all 5 of these options, you can feel free to do so. So we started strong, someone who really wants global budgets. All right. It looks like global budget is still doing quite well. We've got quality and performance at 2 right now. DRG, fee for service at 3, cost-based 4, a little bit more for other. Looks like we have a couple people left, so I'll just give it another maybe 30 seconds. Looks like a pretty strong preference for global budget. Number 2 is quality performance, followed by fee for service, cost base, and then just kind of a nod to other categories. So we'll go on to this one now, which is getting a little bit more specific, but asking what percentage of hospital reimbursement should come from each of these payment types. So you have 100 points that you can choose to spread out. If you don't want to use 100 points or that seems complicated, you can assign 10 maybe to cost base, 10 to fee for service, and hit submit, and it'll automatically split that. So it'll give them 50-50. But also the tool should let you know how many points you have left. And it does increments of 10, but I believe you can change that if you wanted to do 42% somewhere. So a little bit of math, but it tries to help you with the math. All right, we've got our first couple of responses. It looks like 80% global budget, 15% quality, 5% DRG. All right, global budget's remaining pretty strong. We're at 76 now. Quality and performance, it's down to 11. We've got just a little bit in DRG and cost base. Got 6% in each. All right, a few people haven't answered, and if you choose not to, there's nothing I can do about it, but I just want to give everyone some time, so I'll just wait a little bit and then I'll read off our final results for this one. All right, we have most folks in right now. Right now we're looking at 70% global budget, 15% quality performance based, 12% DRG or a fee for service, 4% cost based, and we have a 0% on other. So sorry about that. Okay. My apologies. All right, so our next question here, should all acute care hospitals be reimbursed under the same methodology? The text is small, but left to right, the answers are basically everybody under the same methodology. The second one is adjustments for certain types of hospitals, but predominantly the same. The middle category is critical access, reimbursed differently. The fourth is another specific category, reimbursed differently. And the last option is something else. If you have a completely different idea, feel free to select that category. Right now we have 3 and 3, 3 for adjustments for certain types, and 3 for critical access being called out differently. All right, just a couple more folks here. We've got 1 for everybody under the same methodology. 6 for adjustments for certain types of hospitals. 5 calling out critical access, and 1 calling out another specific category of hospitals. All right, thank you very much. And this is similar, but a slightly different way of asking it, but should any hospital types have special, actually this is different, have special payment considerations? And what I mean by this is being paid under a predominant methodology perhaps, but maybe have some particular adjustment that accounts for their type. And here you can select multiple types. So if you think all of these groups should have some kind of special consideration, you can select all of them. You think none of them, there is a category for that. And if you think that, you know, just 1 or 2, feel free to pick those ones.
I mean, what does district mean in this?
District hospitals, so those are ones that are, they're kind of like government owned, essentially. They're owned by the local district. I think we have, gosh, I want to say 12 in Oregon. That sounds like too many now. We have a couple at least.
I think those local hospital districts tend to have their own taxation base that supports them. Is that right?
Oh.
All right, we've got about half our folks responding now. So I'm going to give it a little more time. Right now, critical access has 10, rural has 9, so a lot of consideration there. 6 for academic medical centers. 1 for district, and 1 person says none. It's going to give it another minute. We still have a couple people left. All right, so we ended up with 11 for critical access, having special payment considerations, 9 for rural hospital, 7 said yes for academic medical hospitals, 1 for district hospitals, 1 for another unspecified group, and 1 said no hospital types should be called out. All right, thank you. very helpful. So now we're going to talk a little bit about global budget, which I was a little worried that maybe folks would say they didn't want a hospital global budget, and I had these questions, but fortunately, that seems to be the overwhelming agreement here. Should physician services be included? And these are, of course, physician services rendered at the hospital. So you can select any one of these. Your options are yes, 100% of the time, yes, and then maybe there are some exceptions. Maternity, certain areas maybe that for whatever reason, there's this idea that it should be different. And then the final option is no, to be reimbursed separately, which is our current model. Right now we've got all yeses, slightly more on the yes with some exceptions, but it's pretty close. So we've got a very broad consensus, yes. We've got one no. All right, so we've got one no. We have 6 yes with some exceptions, and we have 5 yes 100%. Oh, great, thank you so much. So another one on those hospital global budgets, should these apply to both inpatient and outpatient services? Inpatient services being, of course, those that are more than 24 hours, outpatient, generally, you're in and out within a few hours. So our options again, yes, 100%, yes, maybe some exceptions, carve out certain services again, no, stating that only for inpatient, only for those kind of long-term services, and then no, only for outpatient services. We've got a bit of a mix here. We've got 2 right now that say only for inpatient services, 1 for yes with exceptions, 1 for 100%. All right, I think we just have a few more here. Right now we're at about 50% saying global budget for inpatient only. We have 4 saying yes, inpatient and outpatient with maybe some exceptions, and 3 that say yes for all of it. So this could be an area that this looks like something that I think once we're done with this survey, I would love to get a little bit more feedback on, just because we do have, I think, the most variation in opinions on this. So thank you very much. All right, and then a question on sort of the overall construction of hospital payment. What's most important to consider in establishing these hospital payments? So as we're thinking about those inputs, what's going to go into the payment, you should be able to, this is a ranking question actually. So you can rank these, you can rank as many as you want. If you only think a couple are worth putting on your list, that's fine, or you can rank them all. But yeah, what should be considered? Geography, your patient population, that's essentially kind of the risk score of your patient, that hospital status, that goes to some of those other questions, you know, your cost basis, maybe the profit margin needs to be considered, or maybe there's something I haven't mentioned that you think is really important. We'll have to figure out how to share this because it's really interesting to watch it change. All right, we're a little over halfway now. So looks like patient population is pretty strong. Hospital status has also got a lot of votes. And costs, geography is number 4, profit margin 5, something else at 6. Just give it another 30 seconds maybe. And it does kind of, it has different lengths of line depending on sort of that average ranking. Right now it's a pretty pretty clear stair step here. So it's a pretty clear hierarchy that I'm seeing. All right, so patient population comes in the top. So the risk score, hospital status, number 2. Looks like costs are 3, geography is 4, profit margin 5, and something else at 6. So thank you for that. All right, now we're on kind of these last questions. Then there will be a couple open-ended ones, and I'll give it over to the committee to talk about these answers here. But transition, should a new hospital payment system be phased in or implemented immediately? And you have a couple options here in terms of immediate, quick transition, which I would say is 1 to 2 years, moderate, 3 to 5 phase transition. And so my thinking around this, just to clarify, since you all said, I think 70% global budget, if one were to do a transition, maybe you start with a 50% global budget or a 30% global budget, and then it increases in certain increments until you reach whatever that final percentage amount is going to be. And about how many years do you think folks should have in order to make that switch from what we're doing now, which is predominantly fee for service? All right, right now that moderate transition seems to be at the top, the 3 to 5 years, followed by a quick transition. Phased, which is our longest transition, is 3rd, and immediate has the fewest votes, or the lowest ranking, I should say. All right, seems a pretty clear emphasis for that moderate transition, that 3 to 5 years. Quick transition also did fairly well. All right, thank you. And this is just a quick reflection. I want to know if you all found this tool to be helpful, how confident you feel in your responses, and whether you feel that kind of what I've been announcing as the results of these different polls are something that you would be comfortable with staff developing a preliminary proposal for you all to take a look at. So you should be able to slide these scales, note whether you strongly disagree or agree based on the bottom. You're not going to hurt my feelings if you tell me that you didn't really like doing this poll. I just want to know I wanted to try something new. And if it didn't work, it didn't work. So please be honest.
Like Jamie has a hand up.
Okay, sorry, I can't see anything.
I figured you couldn't.
I just thought before we get too far away from the questions, I'm always curious when there's one outlier. What's that person thinking? Is there something that they're seeing that everybody else has been blind to, noticing? I don't worry about that as much when there's a hodgepodge of responses, but when there's a single, like, you guys aren't thinking of this one thing that I'm thinking of. Who's that person? Is, if anybody had an outlier type of response, if they wanted to throw in.
Yeah, and you queued this up perfectly. I'll just give this, and I'll note the next one is a final thought slide, so people can actually type in if you heard that you are an outlier. Feel free to write that in. It can be especially useful if you don't want to have to like go on camera and say your thing. I'll just note that in terms of confidence, pretty neutral, or a 3.3 here. Comfortable with staff. That seems to be an agree, 3.6, and then the survey tool 3.9. So appreciate that. And thank you very much for your comments, Jamie. If you did hear that you were an outlier or you selected something else for any of those questions, would love to get any feedback. Also, just if this raised certain thoughts for you in terms of, I don't know this, this is why I didn't feel confident. Yeah, any kind of commentary at all that you want to share with the group. These are all anonymous, so maybe there's some benefit to that. And you also don't have to respond because it's going to go to open discussion after this. So if you feel like saving it, that's fine. Discussion before answering could be helpful. That's good to know. Thank you. Yeah, like the concrete, more information. Okay. Wonder if we all understood the context nuances. Okay. It's helpful, thank you. All right, don't know enough. An example for the ranked choices would be good. All right, asking for more information about the current payment system. And I guess I just want to ask, because we had a pretty detailed presentation on payment systems. If you can be more specific, like what is it you feel you don't maybe understand about the current payment systems or these new options? For the Hospital Association's ideas, I agree. I think that is a great idea. And I do believe on the communication side, there are some plans for that. I'm not a finance expert and we'll want the hospital. Okay, fair. All right. Well, with that, I think people can continue to submit comments. I will see them. They will show up for me when I go to get this data, but I'm happy to turn it back to you, Chair, for discussion.
Great. Thank you so much. Yeah, you mentioned this, Lee, but yes, we absolutely will be engaging with hospitals as part of our interested parties and gauge their interest in various types of reimbursement strategies and things like the phase-in time and stuff like that. So I think talking to folks who run hospitals will be incredibly useful on this discussion. But I know, I guess I would just say, I feel really confident in the staff drafting a proposal about how we should approach this, including recommendations for here are the things we're not certain of that we need input from the hospitals or hospital association on. Here's a rough draft of our intent, and then here are some questions we would want weigh in from other parties on to bring to us in a future meeting. So I would personally appreciate that. If anyone has any hesitation about staff developing a preliminary proposal, I think, yeah, that would be helpful to talk about now. Anyone? Okay. I don't see any hands, but if anyone else does. Okay. Thanks, Lee. That was great. I really appreciate it. Okay. We're at the end of our meeting. If anyone has any general feedback or reflections about this meeting, this was a little bit of a departure from last meeting where we broke off into small groups, but we had some things to get through today. So any general reflections would be welcome. I'll start with that if anyone has anything to say. Any hands? Okay. And then Isabel, at the beginning, we didn't think there was any public comment. Is there any public comment?
No, there's not.
Okay, great. Then with that, I believe we can adjourn. Thank you all so much for your participation and attendance. We really value your feedback as always, and we look forward to seeing you next month.